Good afternoon. Welcome to our presentation on training clinical educators to lead an interprofessional student team. My name is Rodri Purcell and I'm pleased to be here with my colleague Aaron Frackless. We're both faculty members at Rocky Mountain University of Health Professions in Provo, Utah. The idea for this project was prompted by a couple of opportunities that we saw in our clinical education program. First, like everyone else, we always have the opportunity to expand our clinical site offerings. And second, we saw an opportunity to expand our students' exposure to intraprofessional practice during their clinical education experiences. So, we started by conducting a literature review to find a solution that could help us meet both of our objectives. We quickly identified collaborative learning as an attractive choice because it's first been proven to increase clinical site availability, but also we thought it could be implemented on an interprofessional level to meet our second objective. We found that the literature suggests that clinical educators should be trained in collaborative learning in order for it to be successful, but very few authors talked about how to conduct the training or what content to include in it. So we decided that our first step should be to develop a training course for our clinical educators on how to implement interprofessional collaborative learning. Since the literature was sparse on this topic, we decided to seek input from our local stakeholders, meaning clinical educators and site coordinators of clinical education, to see what they thought should be in the training. We took an action research-based approach because we really wanted to know what our clinical educators' opinions were on what this training should look like. Action research involves collaborating with all possible stakeholders to get their perspective on an issue and help them feel invested in the solution. This approach helped us to build local support for the solution, and it ensured that our final project, the training course, met the needs identified by our local stakeholders. We started by partnering with a local PTA program at Provo College to identify clinical educators that had taken both PTA and DPT students in the past. We thought that these clinical educators would have the best perspective on intraprofessional clinical education. So then we conducted semi-structured interviews with a little over half of the clinical educators that we'd identified as being shared between our two institutions. Then two reviewers conducted qualitative coding on the transcripts from the interviews. Here's what the interviews looked like. If the clinical educator had had previous collaborative learning experience, we asked what they thought made it successful or unsuccessful. And we asked them specifically what their preferences were on content, assessment methods, outcomes, and delivery method. We also asked each person if their setting presented any unique characteristics that would require special training content. This process yielded some useful results. First, a lot of the clinical educators' responses aligned with the recommendations from the literature, but they also pointed to new content areas that we hadn't really seen in the literature relating to the intraprofessional component, such as how to interact in a PT/PTA team, how to delegate to a PTA, and what the PTA's role and scope are. Surprisingly, many of our clinicians felt that they didn't have a good handle on this content area, so we included it in our course content. But probably the biggest benefit of this action research approach was that the process of seeking input and collaboration from our clinical partners created stronger relationships with them and generated a lot of excitement and support for the project. I became a big fan of action research during this interview process. With our evidence-based content list in hand, we started developing our training course. We used the interactive program design model published by Caffarella and Daffron in the development phase because it provided a systematic, structured approach to development. I have a graphic of this model that I can show during the question-answer portion if anyone's interested. We also used Wiggins' backward design method to ensure that our learning activities had a direct link back to our program objectives. And finally, we consulted the literature on best practices for online instruction, since the course would be an exclusively online offering. When it was all said and done, our content fell into 5 broad categories that became the 5 modules for the course. These content areas reflect both local needs as well as the recommendations from the literature. We've built the content around these 5 areas in the Canvas learning management system. We'll deliver the content using these learning activities. We created several role-play videos as problem-based learning opportunities. where participants will watch a clinical educator having discussions with his intraprofessional student team in several clinical scenarios, and then they'll be prompted to identify best practices as well as poor practices and reflect on how they could improve the poor situations. We also used multimedia presentations extensively, as well as some interactive learning activities so that we could appeal to a broad spectrum of learning styles. Since we know that adult learners need to see the relevance in any new information they're learning, we used reflective discussion forums to encourage participants to reflect on how the information relates to their own practice and setting. Now that the training course is built, our next step will be to administer it in a pilot study and use the results to further refine and improve the course. We also want to use a similar approach to create a training program for students, since many authors recommend that students should also be trained if collaborative learning is to be effective. Once both of these courses are online, we'll implement them locally and see how we did. The outcomes that we want to look at initially are, first, how this type of training affects clinical educators' perceptions of interprofessional collaborative learning. Meaning, do they feel more positive about this type of learning model, and do they feel more confident in their ability to implement it? Second, we want to know if the training resulted in increased implementation of interprofessional collaborative learning, and did that translate into increased clinical site availability? These are the first outcomes we want to address, but there are also other lines of inquiry that would be fascinating to pursue. First, the list of benefits from collaborative learning in general is well established in the literature, but would we see these same benefits in an intraprofessional collaborative model? It makes sense that we would, but this should be fleshed out in future studies. Also, does early exposure to interprofessional collaborative learning during students' clinical education experiences result in long-term changes in practice, such as higher utilization of PTAs in the clinic, improved PT-PTA team interaction, or improved delegation skills? These would be interesting topics to explore in the future. Thank you for listening. Here are the references that we used for this presentation, and we'd be happy to share them with anyone who is interested. And now, we'll open up the floor for questions.